We're going to be talking about the three levels of prevention, screening used in secondary prevention, and how we evaluate the quality of screening tests and interpret the results. This includes test validity, reliability, sensitivity, specificity, likelihood ratios, and predictive values. Preventive health is broken down into three levels. Primary prevention is when illness is avoided through health promotion activities and protective actions such as nutrition, hygiene, immunizations. Health promotion is enhancing well-being by empowering people to improve their own health. It recognizes that health is multidimensional and some factors are outside of an individual's control, such as those on the socio-ecological model I introduced in the first class. It's based on the principles of equity, social justice, and health for all. Secondary prevention is early disease detection and treatment. Screening falls under secondary prevention. In this class, we'll talk about the benefits as well as the risks of screening, the principles of screening, and sensitivity and specificity of screening tests. Tertiary prevention is limiting disability and rehabilitation following the diagnosis of disease. Tertiary prevention aims to improve quality of life for those with a disease. 100 years ago, infectious diseases were the leading cause of death globally, but thanks to public health, most of these deaths have been prevented. Immunizations are one of the most successful public health interventions. They prevent 2 to 3 million deaths annually. In addition to preventing morbidity and mortality from vaccine-preventable diseases, immunizations also save the health system overall and governments a lot of money. A cost-benefit analysis of 10 vaccine-preventable infections in 94 low- and middle-income countries estimated a savings of $44 for every $1 spent on vaccinations. This is a good example where an ounce of prevention is worth a pound of cure. I mentioned VAERS, the Vaccine Adverse Event Reporting System, in the previous lecture about public health surveillance. This is one of the national systems in place to ensure that vaccines that are approved by the FDA are safe and effective. The infographic on this slide compares the odds of different events to show severe allergic reactions to vaccines are extremely rare. The odds a child will have a severe allergic reaction after the MMR and hepatitis B vaccines are 1 in a million. The Haemophilus influenza B vaccine is a great example of decreased morbidity and mortality because of an immunization. Back in the 1980s, pediatric ICUs were full of kids with Hib. But in 1984, after the first polysaccharide Hib vaccine was licensed for use in children 18 months of age and older, you can see from the graph that Hib incidence immediately started to decline. And further declines in Hib incidence occurred after the first conjugate Hib vaccine was licensed, and then the Hib vaccines were licensed for use in infants aged 2 months and older. Most people today aren't even familiar with Hib anymore, even though it used to be a really common and serious infection in infants and young children. For screening programs to be possible, we need a disease to have a detectable preclinical phase, and for diagnosis during that phase to change the outcome for the patient. For example, if detection shortly after the biological onset of a disease would not lead to prolonged life or improved quality of life or cure, then we wouldn't be able to do a screening program. It's only for conditions for which detection during this early phase of disease would change what happens for that person that we can decrease morbidity and mortality and improve quality of life with a screening program. The World Health Organization principles for early disease detection should be used as a framework for every screening program. The condition sought should be an important health problem. For example, we wouldn't do a screening program for a condition that is benign. There needs to be an accepted treatment for patients with recognized disease. It wouldn't do any good if we tested people for something and diagnosed them if there was nothing that we could do about it. Facilities for diagnosis and treatment need to be available. For example, it would be unethical if we did a screening program and diagnosed people, but then didn't have any means of referring them for effective treatment. This is important to keep in mind in remote locations because it would be unethical to screen people for a condition if you don't have a way of getting the people access to care for the condition that you're diagnosing. There needs to be a recognizable latent or early symptomatic stage. If a disease is already in the late stages by the time it's diagnosed, it wouldn't be amenable to a screening program. There needs to be a suitable test or examination for the condition, which needs to be acceptable to the population. And the natural history of the condition, including development from latent to declared disease, needs to be adequately understood. There needs to be an agreed upon policy on whom to treat as patients. For some conditions, it isn't straightforward what counts as disease and what doesn't, but this needs to be clarified before undertaking a screening program. The cost of case finding, including diagnosis and treatment, should be economically balanced in relation to possible expenditure on medical care as a whole. For example, if it was very, very expensive to find a case of a condition and that condition wouldn't have a major impact on the life of the individual, it might not be worthwhile on the population level to implement such a screening program. And case finding needs to be a continual process, not a once and for all project. Screening is when we test a person without symptoms to identify an unrecognized disease. This definition is important to differentiate from tertiary prevention, in which the person has already been diagnosed with a disease. The benefit of screening is early disease detection and treatment, leading to decreased mortality from the disease or improved quality of life. But screening does come with risks. One of the risks is false positive test results, which cause stress for the patient and their family, and unnecessary investigative testing, which could be surgery or additional radiation that would otherwise be unnecessary. Screening tests can also cause individuals to incur additional costs, and there can be ethical concerns with screening, like what I mentioned earlier, where if someone is tested for a condition but they don't have adequate access to appropriate treatment, the test result could do more harm than good. A good screening test is easy to administer, inexpensive, causes minimal discomfort, has high validity, meaning it has a high sensitivity and specificity, and good reliability, meaning the results are reproducible. Validity is how good a test is at separating out the people who have the condition from those who don't. And reliability is how consistently the same result is achieved with repeated measurement. Sensitivity shows how well the test performs in people who have the disease, while specificity shows how well the test performs in people who do not have the disease. For screening programs, we usually want to test with a high sensitivity because we want to capture all the people in the population who have or who might have the condition of interest. And it's okay if we accidentally catch some people who don't have the condition with our initial screening test, because we usually follow up with a confirmatory test when doing a screening program. For most conditions, it's better to bring everyone in for follow-up care who may have the condition, rather than accidentally telling people they don't have the disease with an initial test, because then they wouldn't get treatment for the condition. 2x2 tables are used in your textbook, and they're a common way of conceptualizing how well a test performs. This method works well if you're trying out a new test and comparing it to a gold standard test, but it's important to note that this is an artificial way of looking at things that isn't usually how you'll apply these concepts in real life. True positives are the people who actually have the disease who test positive. False positives are the people who do not have the disease who test positive. True negatives are the people who do not have the disease who test negative. False negatives are the people who have the disease who test negative. So ideally, a perfect test would give you all the results in the true positive or true negative squares, because all the people who have the disease would correctly be labeled as having the disease by the test, and all the people who do not have the disease would correctly be labeled as not having the disease by the test. But in real life, no test is perfect. So we often need to weigh whether we want to compromise sensitivity or compromise specificity, depending on what it is we're testing for and what the purpose of our testing use is. For screening tests, we usually favor a high sensitivity, even if that means not having a great specificity, because we want to capture all the people who might have the condition, even if that means having some people get a false positive test result. It's important to note that sensitivity and specificity are both fixed characteristics of the test. They do not change based on the prevalence of the disease in the population you're testing. We calculate sensitivity by dividing the true positives by the true positives added to the false negatives, which is everyone who has the disease. And we calculate specificity by dividing the true negatives by everyone who does not have the disease, the false positives plus the true negatives. A test that is positive in 8 out of 10 patients with a disease has a sensitivity of 0.8 or 80%. A test that is negative in 9 out of 10 patients without a disease has a specificity of 0.9 or 90%. You're the primary care provider for 1,000 people served by a community clinic in Utqiagvik. You recently evaluated several patients with fever, chills, headache, back pain, and generalized weakness. When you took a history to determine possible causes of illness, all the patients with these symptoms recently ate caribou they had hunted in the area. You suspect brucellosis, and there is a new test that can be performed in the clinic. Point-of-care testing would be a great alternative to antibody testing or sending out a Brucella culture to be grown in a lab, which takes many days. The manufacturer of this Brucella test you're considering purchasing for the clinic provides the following. 80 people who have brucellosis got a positive test result. 100 people who do not have brucellosis got a positive test result. 20 people who have brucellosis got a negative test result. 800 people who do not have brucellosis got a negative test result. We can use the 2x2 table method to organize the information provided. 80 people who have the disease got a positive result. 100 people who do not have the disease also got a positive result. 20 people who have the disease got a negative result. 800 people who do not have the disease got a negative result. Then we calculate sensitivity by dividing 80 by 100 for 80%, and we calculate specificity by dividing 800 by 900 to get 89%. This means the Brucella test in this example correctly labeled 80% of the people with brucellosis as having the disease, and it correctly labeled 89% of the people without brucellosis as not having the disease. The sensitivity is the true positives divided by the total population with the disease, and specificity is the true negatives divided by the total population without the disease. It's a helpful convention when using 2x2 tables to put the total population in the lower right corner. Your positive and negative test results should add up to equal the total number of people who were tested. This can be a helpful way of checking to make sure that you set up your 2x2 table correctly. What's the consequence of a false positive test result in the brucellosis example provided previously? If we tell someone they have brucellosis, but they don't actually have brucellosis. One possible consequence would be they might get treated with an antibiotic that might not be helpful for the condition that they actually have, and they may experience side effects they wouldn't have had they not been given the wrong treatment. What would be the consequence of a false negative test result? If we told someone they did not have brucellosis, but they actually did, that could be a problem because we would fail to treat them for the condition that they actually do have, and that may lead to long-term health complications. Therefore, for patient safety, your priority should be to choose a test with a high sensitivity, because we want to label all the people who have the condition with a screening test, and we can follow up to confirm who actually does or does not have the condition with a second test. When dealing with human health, a lot of measures are not a dichotomous result. It isn't as simple as yes or no. We often need to determine a cutoff point for continuous measures. For example, with blood pressure, people's readings occur on a spectrum, and we have to determine as a country or across countries what will count as high blood pressure and what will count as normal blood pressure. We have to make a somewhat artificial determination to draw a line between normal and disease. With the blood pressure example, if we put the cutoff point too high, we would fail to provide nutrition counseling and exercise counseling and medications to reduce the risk of heart attack and stroke in people with an elevated blood pressure that we mislabeled as having a normal blood pressure. But if we put the cutoff point too low, for example, if we said 100 over 70 millimeters mercury is the cutoff between normal and high, then we might erroneously give blood pressure medication and counseling treatment that wasn't necessary to people who actually had a healthy blood pressure. One example of a dichotomous test result in human medicine is PKU, which is an inborn error of metabolism we test infants for. The infant either is positive for PKU or negative. For dichotomous test results like that, we don't have this issue of having to make a decision where the cutoff value should be. The left blue shaded area represents the people who actually have the disease, and the white vertical area is the people who really don't have the disease. On the left are the test results after the entire population was screened. The circles represent individual people to show the distribution of test result values in this population. With the cutoff point like this, the test would correctly label 4 people of having brucellosis who do indeed have the disease, and it would incorrectly label 1 person as having the disease who does not actually have the disease. Meanwhile, the test would incorrectly label 6 people who have brucellosis as not having the disease, while correctly labeling 9 people who do not have the disease as not having the disease. What about the specificity now? It's not as good, but the sensitivity? It's much better with this cutoff point. Now we only have 1 false negative, but 3 false positives. When you increase the specificity, you decrease the sensitivity. Ideally, the range of normal and abnormal values wouldn't overlap, but with real screening test results, they usually do, which forces us to make a decision. We have to decide where to draw the cutoff point, knowing that increasing specificity minimizes false positives, while increasing sensitivity decreases false negatives. When the cutoff point is further to the right, you get a lower sensitivity but higher specificity. When the cutoff point is to the left, you get a higher sensitivity but lower specificity. A lower cutoff, like on the left, is often preferable for screening, so you don't miss anyone with the disease because you typically follow up with everyone who gets a positive screening test result and retest them with a confirmatory test. To reiterate, moving the cutoff criterion line affects sensitivity and specificity, but in opposite directions. Changing the cutoff criterion from 1 to 2 decreases the number of false negatives, it increases sensitivity, but also increases the number of false positives. It decreases specificity. What happens to specificity if we move the cutoff point to the red line? The specificity would be 100%. Everyone without the disease would correctly get labeled as not having it. The take-home point is the choice of cutoff level depends on the relative importance of false positives and false negatives for the disease you're testing for. Here's some more practice questions. You write a grant proposal to provide free hemoglobin A1C testing every 3 months to residents of a skilled nursing facility with diabetes, which has been identified as the subpopulation your organization serves, which is at risk for poor diabetes outcomes. Which level of prevention is this intervention? Is it a screening program? This intervention would be tertiary prevention because the people have already been diagnosed with diabetes and the objective is to improve their health outcomes. This is not a screening program. It's important to note that diagnostic tests and screening tests are not the same. Sometimes they're literally the same test, but when it's ordered in a different context, the results are interpreted differently. There's a local outbreak of pertussis, so you're calling the families of children and young adults without a Tdap or Dtap on their vaccine record to encourage them to come into the office to get a vaccine to prevent pertussis if exposed. Where would the kids you're targeting with this intervention fall in the natural history of pertussis? Explain which level of prevention this effort is and why. While many vaccines can be used as post-exposure prophylaxis following exposure to a disease, the pertussis vaccine is not effective in preventing infection after someone has already been infected or exposed. So everyone you're targeting is before the biological onset of disease. This effort would be primary prevention because you're trying to prevent the disease before it even starts. This is different from secondary prevention, where you're catching the disease in the early stages, or tertiary prevention, where people have already been diagnosed and you're trying to improve their quality of life. Click on the next video to watch part 2 of the lecture on preventive health and screening.